They have to give the... Yes. Hello, dear nursing students. This is Priyadarshini. I welcome you all to the Friday Power Up session of NORCET series under your Plan C Plus English edition. Just let me know whether I'm audible or not. Please comment in the comment box. Okay, fine. So today's topic is SIDH, this is diabetes insipidus, one of the most common and most important topic which is frequently asked in your examination. So simple signs and symptoms, causes and diagnostic evaluations, and what is the drug of choice in case of SIDH and diabetes insipidus. Like many questions used to come from this particular topic. So this is one of the hot topic and the favorite topic for your NORCET and all the examination, which includes your JECMR, ESIC and etc. So, am I audible? Is the voice is not coming? So this topic becomes an ultimately important topic. So that's why I choose this topic today. And the most important thing which you have to listen here is this condition, SIADH and your diabetes insipidus, you should always read these two conditions together so that you will be having a better understanding and better clarity, because they are paradoxically opposite conditions, right? So let's get into the session. Please confirm me my voice is audible so that I'll start with the... Increase the voice once again. I think now it is very well audible. So let's get into the session. So first is SIADH. So what is meant by SIADH? As you all know, SIADH is the SIADH is the syndrome of inappropriate secretion of your antidiuretic hormone. Syndrome of inappropriate secretion of the antidiuretic hormone. So here you can see the expansion of your SIADH. The most important thing you have to remember about SIADH is, as the name implies, it is inappropriate secretion of antidiuretic hormone, which means just like that the antidiuretic hormone is released, which means there is more ADH. The antidiuretic hormone is secreted more, right? Antidiuretic hormone is secreted more. There is too much of antidiuretic hormone which is secreting without any kind of control. It is secreting inappropriately. That is termed as your SIADH, that is syndrome of inappropriate secretion of your antidiuretic hormone. As the definition implies, it is too much of ADH. It is too much of what? ADH. So what is the other name of ADH? Now tell me, what is the other name of ADH? So your ADH other name is vasopressin. Vasopressin. So as the name implies, ADH has two important components. ADH promotes water retention, right? ADH promotes water retention, and ADH also increases your blood pressure. ADH promotes water retention as well as ADH will increases the BP, right? So here the problem, you remember SIADH, right? So SI stands for soaked in, which means there is too much of ADH, so too much of water is inside my body. So to be very clear, okay, to be very clear, I will tell you, ADH is your anti-diuretic hormone. Okay, it is your anti-diuretic hormone. So what is meant by diuresis? Diuresis means increased production of urine. So since the word anti is there, it is what it is doing? It is decreasing the diuresis. It is decreasing the diuresis. It is decreasing the diuresis. So ultimately, what will be the urine output? The urine output will be obviously reduced. So what purpose we are giving diuretic drug? We give diuretic drug to increase the urine output. So here what will happen? Anti-diuretic hormone will decrease the diuresis. So what will happen? Ultimately, there will be decrease in the urine output. On the other hand, you just have to think, like, what will happen to the serum? Like, what will happen to the serum osmolarity if less amount of urine output is there? There will be more amount of fluid overload. There will be more amount of fluid overload. Am I right? There will be more amount of fluid overload, right? Yes. So now, on the other hand, now we are going to discuss about So now we are going to see the opposite condition, that is your diabetes insipidus. So now you can see what is diabetes insipidus. Screen is not visible, now it is visible. Oh my God. Yes, now it is visible. Yes. See, let me repeat it from the first. So first, as we discussed, what is meant by SIADH? SIADH is the syndrome of inappropriate secretion of antidiuretic hormone, which means your ADH, that is your antidiuretic hormone, which is otherwise known as your vasopressin, is secreted inappropriately in the increasing amount. ADH is secreted increasing in the SIADH, right? On the other hand, just come and let us talk about your diabetes insipidus. In diabetes insipidus, it is exactly the same opposite condition for your SIADH. Here what will happen? Here there will be too little ADH. Here there will be too little ADH. Here there will be too little ADH. Here there will be too little ADH, which means the ADH level is so much reduced in this condition. And when the ADH is very much less, as I said you, ADH is the antidiuretic hormone. So when ADH is decreased, when antidiuretic hormone is decreased, what will happen? Ultimately, the diuresis will be increased. The diuresis will be increased, which means there will be more urine output. There will be more urine output. So that is the fine thing, right? So here there is two conditions, that is SIADH and your diabetes insipidus. SIADH, there is too much of ADH, which in turn going to cause excessive amount of water retention in the body. Just remember, SI soaked inside, right? On the other hand, when we talk about diabetes insipidus, in diabetes insipidus there is very less amount of ADH because of nephrogenic origin or because of the central origin. So like we will be discussing about the causes in future. So here what will be there in case of diabetes insipidus? There will be excessive amount of urine production because of excessive diuresis, right? So just remember this thing, anti-diuretic hormone. Anti-diuretic hormone, which means diuretic hormone will promote diuresis, whereas anti-diuretic hormone, what it will do, it will de-promote the diuresis. It will reduce the diuresis effect. So on the same thinking, just come back to the condition. If there is more amount of ADH, what will happen? There will be less diuresis. There will be less diuresis, which means water will be keep on retained inside the body. At last, the urine output is also going to reduce. On the other hand, in the diabetes insipidus, if you see, there will be less ADH. There will be very less ADH. If ADH is going to be reduced, what will happen? Ultimately, there is going to be more diuresis and more urine output is going to be there. Right? Yes. So all about this urine specific gravities we will be seeing. And additional points which you people have to remember here is, the most important clinical and your MCQ key point you have to remember is, where is ADH is produced or ADH is synthesized? Now tell me, where ADH is produced or ADH is synthesized? ADH is produced in your hypothalamus, which is very, very important to note. ADH is produced in your hypothalamus, whereas ADH is released in your posterior pituitary, right? ADH is released in your posterior pituitary, right? So, sorry, this is creating a lot of inconvenience. Let me write here. Once again, please hold on. Please hold on for a few minutes. Yes, sorry for the inconvenience. Okay, so let's start the session from the beginning. As I said we are discussing about SIDH and diabetes insipidus. So as you all know what is meant by SIDH, that is your syndrome of inappropriate secretion of your antidiuretic hormone, right? Here, as I said there will be increased amount of ADH. Here, as I said there will be increased amount of ADH. There will be increased amount of ADH, right? Yes. So on the other hand, we were discussing about the other condition that is exactly opposite to the SIDH, that is your diabetes insipidus. On diabetes, what we have discussed, diabetes will have decreased amount of ADH production. Diabetes will have a decreased amount of, diabetes insipidus will be having decreased amount of ADH production. Yes. So normal mechanism we were discussing in detail. So the normal mechanism is, so your ADH is otherwise known as your vasopressin. ADH is otherwise known as your vasopressin, as you all know. So ADH, as the name implies, it is antidiuretic hormone. It is a antidiuretic hormone. So when it is an antidiuretic hormone, what is the normal mechanism? The normal mechanism which is going to happen because of ADH is, it will reduce the diuresis. It will reduce the diuresis. It will reduce the diuresis. When it is reducing the diuresis, what will happen? It is going to reduce the urine output. So this is the normal mechanism. Now coming back to the condition SIADH. SIADH is a syndrome of inappropriate secretion of antidiuretic hormone, which means there will be increased production of ADH. If ADH is going to be produced more, what will happen? There will be what? If ADH is going to be produced more, what will happen? There will be diuresis will be not happening. There will be reduced diuresis. Okay. Like ADH is antidiuretic hormone, right? So what is its effect on diuresis? It will reduce the diuresis. If ADH is going to be more and more, what it will do? It will more and more, and it reduces the diuresis. If it is going to reduce more and more diuresis, what will happen? Ultimately, there will be decreased amount of urine output. There will be decreased amount of urine output. On the other hand, some additional important points which you have to remember is, so what is the site of production of your ADH? This is very important clinical MCQ point. The site of production or the site of synthesis of ADH, if there is an MCQ, you're going to click the answer. It is hypothalamus. It is hypothalamus. On the other hand, you have to think, like we have another name for hypothalamus, that is the head ganglion of your autonomic nervous system is your hypothalamus. Head ganglion of autonomic nervous system, otherwise known as your hypothalamus. The other name of hypothalamus is the head ganglion of your autonomic nervous system. So specifically in hypothalamus also, exactly where this ADH is produced, if there is an MCQ, then you are going to click it as supraoptic nucleus. Specifically in supraoptic nucleus, right? Specifically in supraoptic nucleus only, this ADH is produced. In the hypothalamus, inside the supraoptic nucleus, this ADH hormone is produced, which is otherwise known as vasopressin. Always remember, ADH and vasopressin are same hormones, right? Or same hormones. Then, again, the most important clinical MCQ point which you have to remember is, what is the site of release? What is the site of release of your ADH? The site of release of your ADH is your posterior pituitary. Always remember, posterior pituitary is not producing your ADH, or it is not synthesizing your ADH. ADH is always synthesized by your hypothalamus, but it is stored and produced by your posterior pituitary. It is stored and produced by your posterior pituitary. This is what you have to remember. SIDH, always remember, increased amount of ADH. Diabetes insipidus, it is decreased amount of ADH. Remember these things. Next we will go to the causes and all. Right? So now we will specifically see about SIDH. Right? So SIDH, what are the causes of SIDH? First is your cerebral toxoplasmosis. This cerebral toxoplasmosis, in what patient cerebral toxoplasmosis risk is higher? When the patient is AIDS positive, because of its immunocompromisation, the patient is at a higher risk of getting this cerebral toxoplasmosis. This toxoplasmosis is very common in what organism? As you all know, it is very high. If the person is having a cat in his home, because of the cat feces is one of the mode of transmitter for this particular disease condition, right? So cerebral toxoplasmosis is the first and primary condition which is very much responsible for causing your syndrome of inappropriate secretion of your antidiuretic hormone, right? So that is also very prevalent in AIDS positive patient. Next is meningitis. As I said you, in SIDH there is increased production of your antidiuretic hormone. Because of any form of infection, which includes your meningitis or encephalitis, there will be increased production of your ADH. On the other hand, small cell lung carcinoma, that is otherwise known as your Oat cell carcinoma, which is another important cause of your SIDH. So what is happening in Oat cell carcinoma or your small cell lung carcinoma? This in turn creates ADH ectopies. Which means when an additional ectopic, as we discussed in cardiology, what is meant by ectopic? Additional abnormal rhythms which is generated in the heart is termed as ectopi. On the same way, you have to think about in Oat cell carcinoma, the ADH ectopies will be formed. If this ADH ectopi is going to form, it is going to produce more amount of ADH, which is ultimately going to cause you syndrome of inappropriate secretion of your antidiuretic hormone, right? And the other causes, which includes any form of lung disease, which includes your aspergillosis, okay, which includes your aspergillosis or aspergilloma and pneumonia, okay, aspergillosis, pneumonia, tuberculosis, intake of drugs such as your selective serotonin reuptake inhibitors and tricyclic antidepressants, trauma to the head, okay, trauma to the head because of the damage to the pituitary stalk. Here it is, you have to remember, when there is damage to the pituitary gland, okay, remember, when there is a damage to your pituitary gland, okay, what will happen? What is the findings? Now tell me, when there is a direct damage to the pituitary gland, what will be the finding? Yes, I want you people to answer in the chat box. When there is a direct damage to your pituitary gland, what will be the finding? When there is a direct damage to the pituitary gland, you will be noticing that the patient will be having decrease in ADH. Okay, decrease in ADH. This is the finding, and this is one of the causes for your diabetes insipidus, which is the condition where the ADH is going to be reduced in amount, right? So now think about it. When there is a damage to the pituitary gland itself, there will be reduced amount of ADH production. But here what I'm trying to tell to you, what I'm trying to clarify to you is, there is a trauma to the pituitary stack, okay, pituitary stack. This pituitary stack is the structure which is controlling the secretion of this particular hormone, that is ADH. So when there is a damage to this pituitary stack, specifically the pituitary stack, then what will happen? There will be loss of control in the secretion of ADH hormone. Ultimately, this is going to increase your ADH production, and which will be the cause for your SADH. Next is strenuous exercise and the tablet vincristine, which is so the strenuous exercise and the tablet vincristine is also one of the important causative factor for your SIADH, right? So coming back to the important elements is, this is where MCQ is going to come to you. And we are clearly describing about SIADH, right? Where there will be what findings is there? There is increased ADH. So increased ADH is there. So there is increased ADH, which means there is decreased diuresis. Okay, increased ADH, which means decreased diuresis and what? This decreased diuresis, so that decreased urine output. Sorry, increased urine output. So here you have to remember what is the volume status. As I said you, SADH is the condition where the antidiuretic hormone is going to be produced more in this particular condition. So what will happen if the antidiuretic hormone is going to be produced more? There will be increased amount of water retention in the body. There will be increased amount of water retention in the body. Always remember SADH, water retention. So what will be the volume status of the body? Euvolemic or slightly hypervolemic. Euvolemic or slightly hypervolemic. So here you can see the word euvolemic, and it is very common in your examinations also. What is meant by euvolemia? Euvolemia means like the patient is already having excess fluid volume only. The patient is having excess fluid volume, but he's not producing n number of symptoms because of it, right? The patient's volume status is quite higher, but it is not so much complicating, but it is quite higher. But when the condition is proceeding further and further, it may worsen, right? And the patient may go for slight hypervolemia because the patient is going for water retention. There is increased water retention because of this particular hormone. So ultimately what will happen? The patient will be projecting what? Slight hypervolemia and euvolemia also. Euvolemia means excess in the volume, but it is not projecting actual symptoms, right? So what about the urine output, which means ADH is increased in amount. So ultimately what will happen? Antidiuretic hormone is decreased. So what happened? Diuresis is decreased. So ultimately when diuresis is decreased, what will happen? The urine output will be reduced. The urine output will be reduced. Because of the reduced in the diuresis process, because of the increased production of your antidiuretic hormone, your urine output is going to be ultimately decreased. What about the serum sodium? Okay, what about the serum sodium? Because of excessive water retention in the body, the patient will be having dilutional hyponatremia. What is meant by dilutional hyponatremia? Excessive water is accumulated in my body. Because of that excessive accumulation of the water, the sodium which is present in my body is going to get diluted, which in turn is going to cause diluted hyponatremia, dilution of the electrolyte sodium. That is termed as your dilutional hyponatremia, right? So how much amount of, as you all know, the normal sodium level is 135 to 145. As you all know, the normal sodium level is 130 to 145, right? Here in this case, what happened? It will go less than 135 millimole per liter. So whenever sodium is given, millimole per liter is equal to, which means 1 millimole per liter. 1 millimole per liter is equal to 1 milliequivalent per liter. This sodium is a monovalent ion. So what happens? If they are giving you, if they are confusing you by giving instead of milliequivalent per liter, if they are going to give you millimole per liter, you should not get confused because sodium is a monovalent compound. So what happened? 1 millimole is equal to 1 milliequivalent. So what is the normal value in millimole? The normal value will be in millimole will be also what? 135 to 145 millimole per liter. So the normal value in milliequivalent is also what? 135 to 145 milliequivalent per liter. So that's how you have to remember. When there is a divalent bond, at that time only the value should be doubled. Okay? So again, what is the action in the serum? What is the action in the serum? So what is the action in the serum in case of SIADH? In case of SIADH, the serum osmolarity is going to increase because there is so much of deconcentration. There is more amount of fluid which is retained in the body. So what happened? The serum osmolarity will be ultimately going to be reduced, which means the serum's concentration is going to be decreased because of excessive volume accumulation or water accumulation. So what is the normal osmolarity? Now comment to be, what is the normal serum osmolarity? What is the normal serum osmolarity? The normal serum osmolarity is 275 to 295. 295 milliosmol per kg. Okay. 275 to 295 milliosmol per kg. So here what will happen, since because of excessive water retention, what is happening? The serum osmolality is going to reduce, which means the body, the fluid inside the body is getting more diluted. So what is happening? There is decreased serum osmolality. Coming back to the urine osmolality, as we discussed, the urine output is reduced because more amount of water is retained in the body. So urine will be so scanty and it will be very less. The urine output will be very less. So what will be the finding? Ultimately, if the urine is very concentrated, very good Priyanka, if the urine is going to be very concentrated, what is the finding? There will be increased urine osmolality. What will happen? There will be increased urine osmolality. Now tell me, like you people have answered about serum osmolality. Now tell me, what is the normal finding of your urine osmolality? What is the normal finding of your urine osmolality? That is 100 to 900 milliosmol per kg. Okay, so this is your normal urine osmolality, which you have to remember. The normal urine osmolality is 100 to 900 milliosmol per kg. In this case, okay, in this case of SADH, ultimately the urine is going to be very much concentrated because very less urine output is there because of the increased ADH hormone. So what happened? Ultimately the urine osmolality is going to be very less than normal, that is less than 100 to 300 milliosmol per kg, right? So what happened to the urine specific gravity? Ultimately, if the osmolarity is going to increase, the specific gravity is also going to increase because of the concentrated urine, right? So in SIDH, what is happening? Your serum osmolarity is getting less, whereas your urine osmolarity and urine specific gravity is going to get increased because of the concentrated urine, right? Now tell me, what is the normal urine specific gravity? What is the normal urine specific gravity? Answer me, what is the normal urine specific gravity? It is 1.0052 to 1.0020, right? It is 020. In some books, it is given 030 also, but you remember 1.005 to 1.020, right? Yes. Some books is given 1.030 also, the maximal level, but you can remember both the things. Like as per the presentation of the options, you have to click the answer, right? So what about the urine sodium? The urine sodium is going to increase. The urine sodium is going to increase, whereas the sodium in the serum is going to decrease. Okay, so the urine sodium is going to increase. The urine sodium is going to increase by greater than 20 milliequivalent per liter due to your natriuretic peptides release in your arteria. Okay, your arterial natriuretic peptide is going to increase, which in turn going to cause increased amount of urine concentration in your, increased amount of sodium concentration in your urine, right? Now let's talk about the symptoms. Right. Now let's talk about the symptoms. So as I said you, the patient will be having the reduced amount of urine output. Yes, obviously the urine output is going to be very much reduced, and the patient will be having sticky and scanty urine, which in turn going to cause increased urine osmolarity and increased urine specific gravity. And the patient will be going for seizures. Whenever the patient is going for hyponatremia, the patient is going to produce what? Seizure-like symptoms because of the cerebral edema, right? Sodium level, which means sodium level is decreased, which is soaked inside, which is going to cause cerebral edema followed by seizures. And the patient will be having severely increased blood pressure, and the specific gravity of the urine is increased, and absence of pedal edema. You have to note this point clinically, why the pedal edema is absent in case of your SIDH. Obviously, we were discussing there is excess amount of volume retention, the patient is having excess amount of water retention. So why there is no pedal edema? Anybody can guess me? And anybody can answer me why there is absence of pedal edema? Why there is absence of pedal edema? always remember, pedal edema happens because of the accumulation of both, because of the, okay, pedal edema. Okay, pedal edema happens because of accumulation of both your sodium and water. Sodium and water. Sorry. Sodium and water. So when sodium and water both are accumulating together, okay, in some conditions, this is going to cause what? Edema. This is going to cause edema. But here in this case, only water is retained. Sodium is not retained. Only water is retained. So that's why the patient will not having any form of pedal edema, right? And in normal mechanism, that is what I was discussing with you. In normal mechanism, what will happen? When sodium and water both are accumulated in the body, which is going to cause pedal edema, when only water is retained in case of SIDH, so there will be no kind of edema, right? And it is also an euvolemic state, that also you have to remember. So next, what is the CNS effects? Obviously, because of the less amount of sodium, there will be seizures, confusion because of the less amount of sodium. So what is the confirmatory test of SIDH? Again, this is an question point. Okay, question point. There will be reduced serum osmolarity because of the diluted fluid, and urine osmolarity will be increased. Euvolemia will be there, and increased urine sodium will be there, and water loading test is the diagnostic test for your what? SIDH. So what is meant by water loading test? They will be giving excessive amount of water to the patient and they will be analyzing. Even after giving excessive amount of water, the patient will be producing very little amount of urine output. Thereby, we are confirming that the patient is positive for SIDH. Yes. So what is the management of your SIDH? So first, we have to correct the sodium. So sodium is corrected by means of your 3% hypertonic saline. Slow correction should be done. If there is overcorrection, what is the conditions? Please put in the comment box. Yes. If I'm doing sudden corrections of the sodium, what is the finding? What will be the condition I'm getting if I'm suddenly correcting more amount of sodium? In 24 hours, I'm increasing the sodium to 20 milliequivalent. What is the condition? Now you have to put in the chat box. Yes, coming back to the session. So management of hyponatremia is with 3% hypertonic saline, and always remember sodium correction should be done in slow method, and it will lead to a preceding condition that you people are going to answer me, right? So less than 20 milliequivalent per 24 hours has to be corrected. If it is going more than that, it is going to cause severe form of complication, and an important condition that you people have to tell me. So next is the management. In the management, in case of chronic SIDH, you have to instruct the patient for fluid restriction. You have to instruct the patient for fluid restriction for less than 800 ml per day. And the drug which is very important is your tolvaptan. So tolvaptan is the drug of choice for your SIDH in case of a chronic condition. So it is an V2 agonist. So now we have discussed a lot about your hypothalamus and ADH. So ADH is produced in the hypothalamus, and it is synthesized and produced in the hypothalamus, and it is released by your posterior pituitary. Now tell me, what is the mechanism of action? What is the mechanism of action? This ADH is specifically acting in your collective duct of your kidney. It is specifically acting in your collecting duct of the kidney. In collecting duct, we have an important component that is a V2 receptor. That is a V2 receptor. V2 receptor. So what ADH will be going and acting on this V2 receptor. ADH will be going and acting on this V2 receptor so that it will cause what? H2O absorption into the body. Okay. This mechanism of action of ADH is specifically happening in your collecting duct of the kidney, where excessive amount of what? Where excessive amount of water is reabsorbed. This reabsorption is happened by your V2 receptor okay, by your V2 receptor. Okay, by your V2 receptor, be very clear, it is a V2 receptor, like I'll write it clear. By your V2 receptor, right? So when this V2 receptor, when we are blocking this V2 receptor, what will happen? The drug tolvaptan is doing that action only. When I'm going to block this V2 receptor, ultimately I'm going to reduce the H2O absorption. Ultimately I'm going to reduce the H2O absorption. That's why tolvaptan is a drug of choice in case of the chronic management of your syndrome of inappropriate secretion of your antidiuretic hormone. Very good, Sonia. Acting on V2 receptors in the collecting duct and causing H2O reabsorption. Very good, Sonia Mishra. I'm very proud of you. Okay. So here again, coming back to the management. So just remember about these questions. Like, what is the diagnostic test for SIDH? It is your water loading test. And what is the drug of choice, or what is the drug of choice in managing your chronic SIDH? It is your tolvaptan. What is the action of tolvaptan? It is the V2 receptor antagonist. It is an antagonist. Agonist means which is promoting. Antagonist means which is preventing, right? So nursing priorities in the management of your SIDH is vitals. Very good, Mona Lisa. Vitals monitoring you should be doing. Seizure monitoring, seizure precautions you have to give. Provide safe environment to the patients. Intake output chart monitoring should be there. You have to monitor how much, and fluid restriction you have to advise. So it is very important to monitor intake output. Daily weight monitoring to assess how severity of fluid retention is there. And fall risk prevention has to be done, because the patient is going for higher risk for seizure and the patient is going for hyponatremia. So there is a lot of chance the patient will be going for confusion, right? So oral care has to be given, and elevate the head end of the bed. So what is the mechanism behind elevating the head end of the bed is, like, it will decrease the venous return, thereby the baroreceptor mediated ADH release will be reduced. So when there is an hyperactivation of your baroreceptor, this in turn again going to be an additional factor which is going to increase the ADH level in the body. So when we are going to give an elevated head end, so in this case, what happened? The intrathoracic pressure, everything is going to reduce, and the baroreceptor stimulation will be reduced. Thereby, the baroreceptor will not stimulate to produce more amount of ADH, right? Then, in lab monitoring, what are the findings you can see? In lab monitoring, you can see the serum sodium, okay, and serum osmolality, urine output, and uric acid will be also reduced. So it is very, very important to note the patient will be going for hypouricemia in case of SIDH. The patient will be having normal creatinine, all the values will be normal, because the problem is only in the water reabsorption, right? So all the KFT, LFT findings will be normal, but the patient, because of the over dilution of the electrolytes in the body, the patient will be also having, then another additional important point you have to remember is, the patient will be having hypouricemia. The uric acid level will be reduced to 2 mg of TL because of the urine, right? So danger of overcorrection of your sodium will lead to central pontine myelinosis. Central pontine myelinosis, which is also a very important point you people have to remember, right? So now we will talk about diabetes insipidus, then we will discuss about MCQs, right? So now let's, in comparison, we will learn diabetes insipidus and your SIDH, right? So here you can see, yes, so here you can see, as I said, your SIDH is increased ADH and diabetes insipidus is decreased AGH, right? So here, what is the causes of diabetes insipidus? And the most important thing you have to remember is, diabetes insipidus is having two types. Diabetes insipidus is having two types. One is your central diabetes insipidus, okay, central diabetes insipidus, and your nephrogenic diabetes insipidus. Okay, it is your central diabetic insipidus and nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. So two conditions you have, and two condition has different findings, right? So what is the causes of central diabetes insipidus? When the term implies there is something problem in your central system, right? So when there is an head trauma, when there is an head trauma, when there is an head trauma, when there is an head surgery, okay, when there is an head surgery which is indicating like any form of pituitary surgery, and if there is any tumor, okay, which in turn going to affect the production of your ADH, in that case what happened, the patient will be having central diabetes insipidus, which is the action what? What is mean by central diabetes insipidus? Because of the affection of the production glands, so I am getting reduced amount of ADH, that means I am getting central diabetes insipidus. On the other hand, when you talk about nephrogenic diabetes insipidus is indicating the problem is not with the production of the ADH, but the problem is in the absorption, utilization of the ADH. As I said, your V2 receptor is one of the most important receptor in the process of your ADH activation, right? So here, when the V2 receptor is misleading, or it is doing any problem, or it is not working properly, in that case only you will be getting nephrogenic diabetes insipidus. So what is the precursors of nephrogenic diabetes insipidus? First is your lithium. This lithium will block, the action of lithium is to block what? Is to block your V2 receptor. Action of lithium is to block your V2 receptor. Okay, action of lithium is to block V2 receptors. So ultimately, if you block V2 receptors, what happened? Even though I have a good amount of ADH, if V2 receptors are not working properly, the ADH cannot be utilized properly, right? So that is one of the reasons here, right? So next, what are the other reasons? Okay, the important thing you have to remember, MCQ point you have to remember is, lithium is one of the cause of your what? Nephrogenic diabetes insipidus, which is not central related, right? So lithium you people have to remember definitely. Lithium is one of the important drug which is causing nephrogenic diabetes insipidus. Amphotericin B is another drug, and hypercalcemia. When the patient, like increased amount of concentration of high calcium can also precede to your nephrogenic diabetes insipidus, which is causing nuisance in the kidney. And sickle cell anemia, where there is an accumulation, like sickle cell cells is there and they are accumulating the important vessels. So that in turn also be the cause of your what? Nephrogenic diabetes insipidus. Hypokalemia is another cause. But in this condition, you have to remember, in case of central diabetes insipidus, obviously the ADH is reduced. But in case of your nephrogenic diabetes insipidus, your ADH will be what? Your ADH will be increased only, but it will not be utilized proper because of your V2 receptor misbehavior. About the volume status. So now see here. So here euvolemia was there in case of your SADH. In case of your diabetes insipidus, where your ADH hormone is reduced, the patient will be having hypovolemia. And what about the urine output? Because of the very much reduced antidiuretic hormone, there will be polyuria will be there to the patient. What is that? Polyuria will be there. And specifically, what is the definition of polyuria? When there is an urine output of greater than 3 liters per day, we are terming it as polyuria. On the other hand, if the patient is going to have polyuria, the patient paradoxically he will be having polydipsia, where he is going to consume more amount of water. What is the definition of polydipsia? Polydipsia, when the patient is consuming more than 6 liters of water per day, that we term it as polydipsia, right? And what about the serum sodium? Because excessive urine is released from the body. So what will happen? The body will be having very less osmolarity. The body will be having what? The body fluid is very much less. So the osmolarity is ultimately it is going to be very much increased, right? So the patient, because of the excessive fluid osmolarity, water is very much less. This in turn going to cause relative hypernatremia. It is going to cause relative hypernatremia because of excessive fluid loss. Relative hypernatremia. relative hypernatremia, right? So it will be greater than 145 millimole per liter. And what about the serum osmolarity? The serum is very much concentrated because of the excessive fluid loss. So ultimately the serum osmolarity is going to be reduced. And what about the urine osmolarity? Urine is very much dilute. More amount of urine is going. Polyuria is there. So obviously what will happen? There will be very reduced amount of urine osmolarity. And what about the specific gravity? Again, the specific gravity of the urine also will be very much reduced because it is a very diluted urine which is coming out. So what about the urine sodium? The urine sodium in case of your diabetes insipidus will be normal. So what are all the symptoms of your diabetes insipidus? First is your diuresis, excessive amount of urination, polyuria will be there, and diluted urine will be there, because like in normal, it is not a normal, because of reduced amount of ADH, the body is producing more urine and it is causing more polyuria. So diluted urine will be there, and patient will be going for dehydration because of excessive water loss and drinking a lot of water, that is polydipsia, and the definition of polydipsia is greater than 6 liters per day, and decreased PP and postural orthostatic hypotension will be there. So what happened? You will be monitoring the BP of the patient in the lying position. Then after 3 minutes, you are asking the patient to stand, okay, and you will be monitoring the blood pressure. Then if you see the systolic and diastolic blood pressure are decreasing, which means it is orthostatic hypotension, which is seen in case of your diabetes insipidus. And desmopressin response test will be done in order to identify whether it is a central diabetes insipidus or it is a nephrogenic diabetes insipidus. As I said you, in central diabetes insipidus, what is happening? The problem is in the ADH production, there is decreased amount of ADH. Whereas on the nephrogenic diabetes insipidus, it is the problem in what? It is the problem in the V2 receptors. So in desmopressin test will be used to confirm the problem is in the central part only, right? Yes. Next is the CNS effect. The patient will be having irritability, coma, and if severe hypernatremia is there, the patient will be go for severe irritability and coma. And next is confirmatory test for your diabetes insipidus is water deprivation test. What is meant by water deprivation test? I am going to ask the patient to not have water for some period of time. Even after I am doing that test, if I am drinking very less water, what will happen? Obviously, I will get very less urine. That is the normal output, right? So here in case of your diabetes insipidus, even after drinking less water, or the patient is advised for water deprivation, the findings will what? After that also the patient will be getting diluted urine. So that is the classical finding and confirmatory test for your what? That is your diabetes insipidus. So water deprivation test, what is the other name? It is Miller-Moses test. And plasma copeptin will be also positive, which is another component which is releasing along with your ADH, and desmopressin challenge test will be also positive. So what is the management of your diabetes insipidus? That is your free water replacement, 0.45% NS because of excessive dehydration, and desmopressin. So desmopressin is a synthetic form of ADH. It is a synthetic ADH which is produced artificially, and it is given as a replacement for your antidiuretic hormone. Since in case of central diabetes insipidus, the problem is in the reduced amount of ADH, so obviously synthetic ADH we can give. The name of the drug is desmopressin, which is again a question point. Right. So in case of nephrogenic diabetes insipidus, what will be the findings? In case of nephrogenic diabetes insipidus, there is no problem in the ADH, but the problem is in the V2 receptor. So what you're going to give? You're going to give thiazide diuretics. Again, you can ask me, like, already the patient is going for polyuria, and again you are asking me to give diuretic drug. Thiazide diuretic is a diuretic drug, right? So what is the clinical finding here? See, just we are giving thiazide diuretics in order to reduce the polydipsia effect. Okay, We are specifically giving thiazide only to nephrogenic diabetes insipidus. That too, for what purpose we are giving? In order to reduce the excessive thirsty effect, polydipsia, to that particular patient. So why thiazide we are giving? It is to reduce the thirst mechanism in the osmoreceptors. And along with that, we are going to give amiloride also. So what are the nursing responsibilities you have to do? You have to monitor for dehydration, BP, daily weight monitoring, skin turgor you have to assess, neurological status you have to assess, provide safe environment to the patient. And what about the findings? Lab monitoring, serum sodium is going to be increased, urine output is going to be, serum sodium, urine output, serum osmolality, and weight loss, everything you will be monitoring in case of your diabetes insipidus. And what is the danger of overcorrection of your hypernatremia? It will lead to cerebral edema. Right? Now coming back to the MCQ part. Now you have to answer me with the correct answers. Is the screen is visible now properly? Yes. Now it's time for you people to answer me with the correct answers. Yes. Very good, Sonia. Very good. Sonia has already answered correct. Yes. Administration of 3% hypertonic saline slowly is the correct answer. So let's read out the question. Which nursing intervention is most appropriate for a patient with acute symptomatic hyponatremia? What is meant by symptomatic hyponatremia? Which means the patient is possessing critical symptoms because of hyponatremia. So obviously symptomatic hyponatremia is the medical emergency, It's a medical emergency. So immediately you have to do the management with your 3% hypertonic saline. Rapid IV infusions, it is not effective. Administer desmopressin. Already SIDH is the problem in overproduction of ADH. Desmopressin is a synthetic component of ADH. It is a synthetic component of ADH, right? Synthetic ADH. If you are going to additionally give ADH, it is going to worsen the symptoms only. Restrict fluids to 2 liters per day. It is not advisable. Very good. Many students have answered it. Very good. Very good, Sonia. Very good, Dibesh. Very good, Devi, Priyanka, Saranya, Mari, Srilin, Joy. Very good, very good, very good. So proud of you people. So let's go to the next question. Okay. The nurse suspects nephrogenic diabetes insipidus in a patient. Which drug the patient's history supports this diagnosis? Now tell me, which of the following drug involved in this causation of this particular condition? I'm waiting for you people's answer. Yes, Priyanka, Mona Lisa, you people have my heart. Lithium is the correct answer. As we discussed earlier, lithium is the drug which is the one factor, important factor, which is going to cause nephrogenic diabetes insipidus. Why? Lithium has the effect on your V2 receptors and aquaporin. So that is one of the factor which is an ultimate factor for causing nephrogenic diabetes mellitus. Now tell me in the comment box, vincristine is a causative factor for which particular condition? So now lithium is the correct answer. Yes, obviously many people has answered me very good. Like congratulations to Priyanka, Mona Lisa, Saranya, Devi, Sonia, Mari, Debesh, Saranya. Bipolar disorder. What is this name? And Strelin, very good. Lithium is the correct answer. Now tell me, I have discussed about vincristine, which is also one of the causative factor in either SIDH or your diabetes insipidus. Now you have to tell me vincristine is a causative factor in which particular condition? Vincristine is a causative factor for your SIADH. It is a causative factor for your SIADH. Tolvaptan. What is the action of tolvaptan? Tolvaptan is used in the management of what? Is used in the management of your what? Nephrogenic diabetes insipidus. Am I correct? Yes, very good, very good. Now tell me about desmopressin. Desmopressin is the synthetic ADH. Synthetic ADH. See, like, because of some presentation, like the view issue, but I hope that you people understood the basic concepts. That is very much important before going for your examination. Right? So obviously, nephrogenic diabetes, supporting is your lithium is the correct answer. So vincristine is one of the causative factor of your SIDH. Tolvaptan is a drug of choice when used in the management of your nephrogenic diabetes insipidus. Very good. Desmopressin is a synthetic ADH which we are going to administer in the management of your chronic syndrome of inappropriate secretion of your anti-diuretic hormone. Right? So let's go to the next question. Yes. Now tell me the answer. During a water deprivation test, a nurse notes that the patient's urine remains dilute despite fluid restriction, but does not respond to desmopressin. What is most likely the diagnosis? Now I need the answer. During water deprivation test, a nurse notes that the patient's urine remains dilute despite fluid restriction, but does not respond to desmopressin. What is most likely the diagnosis? Yes, very good. Priyanka, a big round of applause to you. Yes. Nephrogenic diabetes insipidus, as we discussed earlier, nephrogenic diabetes insipidus is not actually the problem with what? Nephrogenic diabetes insipidus is not actually the problem with your decrease in ADH, but the problem is with your V2 receptors. So this particular nephrogenic diabetes will not respond even after doing a desmopressin test. So desmopressin test is a clinical indicator that the patient is a central diabetes insipidus. But here when he is not responsive to desmopressin test and water deprivation test, then we are confirming the patient is a case of nephrogenic diabetes. Crystal clear? Comment crystal clear when you completely understand the concept. So central diabetes insipidus, the patient will be not responding initially, but later he will be responding to the desmopressin test. Right. So what about SIDH? In SIDH, what test we use? You tell me, in SIDH, what test we do? In diabetes insipidus, we will be using water deprivation test. So in SIDH, what test we will be using? Please put in the comment box what test we will be using in the SIDH. I'm waiting for your answers. Very good. Water loading test is done in case of your SIDH. Water loading test. Right? Now tell me, what is cerebral salt wasting? In cerebral salt wasting, what are the conditions we will be having? What are all the symptoms you will be having? In cerebral salt wasting syndrome, what are all the findings you will be having? In cerebral salt wasting syndrome, what are all the findings you will be having? In cerebral salt wasting syndrome, you will be having hypovolemia, hyponatremia, And increased amount of urine sodium will be seen in case of your cerebral salt wasting syndrome. Seen in case of your cerebral salt wasting syndrome. Now coming back to the next question. Now tell me, what is the most critical nursing action to prevent complications in a patient with chronic SIDH? What is the most critical nursing action to prevent complications in a patient with chronic SIDH? Now answer me. Administer loop diuretics with potassium supplements. Encourage 2 to 3 liter fluid intake. Restrict the fluid intake to less than 800 ml per day. Administer isotonic fluid to maintain hydration. Yes, Priyanka, Devi and Saranya, you answered it very correctly and appropriately. It is restriction of fluid intake to less than 800 ml per day. Restriction of fluid intake less than 800 ml per day. Why we are doing it? Already in SIDH, what is happening? Excessive fluid retention is there, water retention is there. Additionally, you're not supposed to give more amount of fluid. Therein, in order to reduce the chronic complications of your SIDH, you have to restrict the fluid intake of that particular patient, right? So that you can reduce the amount of water retention as well. Now the next question. Yes, it's an application based question. Is it visible? Yes, 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 yes. A 62 years old male post-operator from transsphenoid pituitary tumor. So now you should come with a conclusion. Like, because of transsphenoid pituitary tumor resection, he is admitted to the neuro ICU. On day 2, the nurse notes confusion. The patient is having confusion, headache and drowsiness, and serum sodium level is decreased. Serum sodium level is decreased. Okay. And urine output is low. Urine output is low. Okay. Sodium is, okay, what sodium was given? Like serum sodium is less. Okay, serum sodium is less. Okay, urine output is low. Urine osmolarity is increased. Urine osmolarity is increased. Serum osmolarity is also like 260, which is also decreased. Now tell me, BP and skin turgor is normal. What is most likely the cause of this condition? What is most likely the cause of this condition? Obviously, because of your SIDH, due to surgical stress, the patient has gone for your syndrome of inappropriate secretion of your antidiuretic hormone, right? So just coming back to the question, review it. Like, you can get questions like this. There is a lot of chances like you can get questions like this. Giving all the values, they can will ask you to identify what is the condition. So confusion, headache and drowsiness, which indicates the patient is going for hyponatremia related symptoms. And the serum sodium level also they have given, it is very much less, that is 119. And the urine output is low. As you all know, in case of SIDH, there will be excess amount of water retention in the body because of excess production of ADH. And the urine osmolarity will be obviously increased because the concentrated urine is coming out of the body, right? So serum osmolarity, obviously there is an excessive water retention which in turn going to cause dilution of the fluid in your body. That is going to cause reduced amount of osmolarity. And BP and skin turgor is quite normal, right? Because it is euvolemic hypervolemia, right? So what is most likely the diagnosis? Obviously it is your SIDH. Very good, Saranya, very good, Priyanka, Sonia and everyone. Now with the same into answer the next question. An ICU nurse receives order for a patient with SIDH. The serum sodium is 118, which is very much reduced, presenting with generalized tonic-clonic seizure. Vital signs is 130/80 and heart rate is 100 and respiratory rate is 24, urine output is low and concentrate. Which of the following is the best immediate nursing action the student, which of the following is the best immediate nursing action the nurse should do? Now tell me, it is a nursing priority based MCQ. Now tell me what is the correct answer. Infuse normal saline rapidly to rise the sodium, which is not going to work. Start slow 3% hypertonic saline and monitor sodium every 4 hours. Yes, it is a very important intervention. Yes, that is the correct answer as well. And Devi Priyanka has answered it very beautifully regarding this. And administer desmopressin intranasally. No, it is not the appropriate management. Yes, very good, Sterling also. So now we will go to the next question. In managing a patient with chronic SADH, the nurse elevates the head of the bed to 30 to 45 degree. What is the rationale for this position? What is the rationale for this particular position? What is the rationale for this position? Why we have to elevate, as we were discussing? In order to decrease the baroreceptor mediated ADH production, we were putting the patient in the elevated bed, that is in the semi-Fowler's position, right? So obviously the correct answer is to decrease the baroreceptor mediated ADH activity, ADH release. We are putting the patient in the what? 30 to 45 degree elevation. Yes. Now, the next question. A nursing educator is explaining a ADH physiology. Which nephron segment is primarily, it's a primary site of ADH action, responsible for water reabsorption? Yes, now tell me the answer. Very good, the previous answer, students, very, very good. Now answer for this new question. A nurse educator is explaining ADH physiology. Which nephron segment is the primary site of ADH action? Yes, as I said you, the action of your antidiuretic hormone, which is produced in the hypothalamus and which is released by your posterior pituitary and which is acting. The mechanism of action is in the collecting duct of your kidney. So collecting duct is the correct answer. All right. So here, with the help of a V2 receptor, they are helping in H2O reabsorption. So these are very, very important points to remember, because SADH and your diabetes insipidus are very commonly asked in the examination. So very good. Please give a big round of applause to bipolar disorder, Priyanka Patra, Saranya, and your Dibesh. Yes. So next time I will try to put in PPT only, because this is not convenient, right? So next time I will try to put in PPT only, so that it will be easy for you people also. There was a lot of distraction because of it, right? So next time I'll try to put PPT so that it is effective. So coming back to the next question. What laboratory parameter, aside from sodium and osmolality, is often decreased in SADH and should be monitored? Now answer me correctly. What laboratory parameter, aside from sodium and osmolality, is often decreased in SADH and should be monitored definitely? As I said you, yes, I'm just waiting for your answer. Yes, very good, Saranya. Saranya has picked the point. So here, along, not only always we will be concentrating on sodium in case of your SIDH and your diabetes insipidus, but here is a key factor, that is your uric acid. The patient will be going for hypouricemia in case of your what? In case of your SIDH. So along with other parameters such as your sodium and osmolality, Uric acid level monitoring is also very important. Whereas if you take about creatinine and potassium, it will be normal only, and chloride does not have any interaction with SIADH. But creatinine and potassium value will be normal only, right? So now let's go to the next question. Yes. A nurse is correcting serum sodium in a patient with severe chronic hyponatremia due to SIADH. Which of the following complication is most feared if sodium is corrected too rapidly? Now tell me what is the condition which is going to cause as a complication for rapid sodium infusion. Yes, central pontine myelinosis is the condition. Very good, very good, very good, very good. Central pontine myelinosis is the correct answer. If you're doing a rapid correction for your hyponatremia, which is greater, if you're doing it greater than 10 milliequivalent per liter in 24 hours, okay, in 24 hours, this is going to ultimately lead to your central pontine myelinosis in your neurology system. So now again a next application based MCQ. A 58 years old male with small cell lung carcinoma develops SIADH. The nurse notes the serum sodium is 118, patient is drowsy, intermittently disoriented and has pedal edema, no pedal edema. BP is 132/84, respiratory rate is 18, heart rate is 90 beats per minute, and scanty but concentrated urine is there. Physician order 3% NaCl, fluid restriction and seizure precautions has to be followed. So as a primary nurse, which of the following is the highest immediate nursing priority? Again, I'm reading out the question. A 58 years old male with small cell lung carcinoma develops SIADH. Her serum sodium is 118, which is decreased, and the patient is having the drowsiness, intermittent disorientation, and has no pedal edema. And BP is 132/84 mm of Hg, respiratory rate is 18, heart rate is 90, urine is scanty but concentrated. Physician ordered 3% NaCl, fluid restriction, and seizure precaution is also carried out. As a nurse, which is the primary and highest immediate nursing priority? So that is the question. Now coming back to the options, now tell me what is the correct answer. Insert an indwelling catheter to monitor a Horley urine output. Maintain strict fluid restrictions of 800 ml per day. Elevate head end of the bed to reduce the ADH secretion. Implement seizure precautions and monitor the neurological status Horley. Now tell me, what is the answer? So since the patient is possessing with drowsy, intermittent disorientations and all the complications, and the serum sodium level is also very much decreased, so the patient is going for seizure. There is a lot of chance the patient will go for seizure. So your highest priority action will be in order to prevention of the seizure. So that is you implement the seizure precautions and monitor the neurostatus every Horley, right? Every Horley you have to monitor this. So we were discussing about monovalent ions in relation to your, right? We were discussing about monovalent ions in relation to your, right? Monovalent and divalent. So remember this additional component, monovalent and divalent. So monovalent is your sodium. Then additionally, what are all coming under your monovalent? Sodium, potassium, chloride, HCO3, all are monovalent. Whereas your magnesium and calcium are your divalent. Magnesium and calcium are your divalent. So here only you have to remember, when they give millimole value, okay, milli or small per liter. So here this is 1 is equal to 1 only. But here 1 is equal to 2. Right? You have to double the value and check. 1 millimole per liter. In case of divalent bond, 1 millimole per liter is equal to 2 milliequivalent. This is an additional information I'm giving to you people. You have to remember this. So whenever sodium level is 135 to 145 milliequivalent liter, and again the millimole per liter value will be also 135 to 145 millimole per liter. For potassium also it will be same, for chloride also it will be same, for HCO3 also it will be same. But if you talk about divalent bonds, that is basically your magnesium and calcium, please keep it in your mind. So if magnesium and calcium values are given, you have to double the value. If it is given in the millimole, if it is in milliequivalent, you will be very clear about what is the range. But if it is given in the millimole, you have to double and calculate and do it. Right? I hope this session was very much helpful for you people, and thanks for watching, and please put your feedbacks in the comment box. I want to see. So thanks for watching, and all the best for your wonderful preparation for your examination.